Clinton from the Heart of Medicine, and this video is going to be the internal medicine pearls video number 15, I believe. Let's see how many we have in the oven. Yeah, this is number 15. So as I study for the internal medicine certification examination, I'm just sharing with you guys the pearls, main things I learned that might help you out in the certification examination. If you're a internal medicine resident, I believe this is going to be pretty helpful. If you're a medical student, a resident in internal medicine, or a physician, in general, this is probably going to be helpful. There's a lack of these videos on the web, so this video purpose is for you to do your thing. You can be in the grocery store buying things, and you can have your earbuds on and just listen through these things. So I'm not going to waste any more time. Let's go to the action. In this quiz, this set of 14 questions, I got destroyed compared to the other ones. This is one of the worst ones, so I think the most learning will come from these, of course. The ones you fail forward, okay? So what's the first point with this question? So question number one, we're not going to go through the whole thing. We're just going to focus on the pearls, things you have to take home. So just look at this x-ray right over here. Think about it. I'm just going to give you the basic information. This patient is not having a bowel movement. So the patient has a distended abdomen, has abdominal pain, does not have rebound, does not have Garden. The abdomen is not rigid. But yes, there is diffuse abdominal pain, and you have this x-ray. You also have a CT report. So there's some information regarding the CT. And the CT, oh, let's go back here so you didn't see the answer. Let's see. Well, the abdomen image says there's large air-filled sigmoid colon with absence of air in the rectum. Okay, that's what you have. Those are the main points. The lab's just very mild leukocytosis. The rest is normal. And of course, they're giving you lactic acid for you to think about, rule in or rule out the mesenteric ischemia. Lactic acid is normal. This patient does not have mesenteric ischemia, and of course, you wouldn't expect these imaging findings. So when I saw this question, I just looked at the X-ray, and I just focused too much on these things, and I just was like, oh, okay, no distal air. I didn't see any distal air right over here. So I'm like, okay, yeah, abdominal obstruction. Maybe this is very horrible constipation, but I didn't see the elephant in the room, which now I see it, of course, after I got it wrong. What I want you to see here is the volvulus. This is a sigmoid volvulus. The most common place of volvulus in the intestinal tract in adults is going to be the sigmoid colon, and here you can see the volvulus, which is a torsion on itself of the colon, right? It is very, very infrequent to see volvulus of the small intestine. It's usually going to be the colon, and most often the sigmoid, and this that you're seeing right here is the volvulus. Since you have this twisted on itself, that's why there's no distal air, and that's why the patient cannot poop and is having the abdominal pain and all that. So the question was asking, what should be the next step? What is the treatment for this patient? And since I thought this was horrible constipation, I didn't pay much attention to it. I was a little distracted taking the timed test mode of things. Maybe I read this a little too much, I don't know. But in summary, I thought it was, oh, sodium phosphate enema. Okay, well, you can see that a lot of people answered this same test option. So it wasn't an enema. That enema would work if you have a constipation, yes, but an enema will do nothing if what you have is a volvulus. What's the treatment for these volvulus? So you can do it the non-invasive route or the more invasive. Most of these patients, ideally, if you can do the more conservative approach, better to do that, which is just you do a flexible sigmoidoscopy, and that will untwist or unwind the volvulus oftentimes. And many providers oftentimes put in a rectal tube through and past that volvulus, and that is able to also decompress the bowel loops a little more. And at least that can fix the problem. But there's a lot of these that recur. So at least it can give you time to plan out the surgical intervention as well. So that's the answer, flexible sigmoidoscopy. What else can we talk about here? I'm just going to show you the image here showing us the volvulus. So here you can see it. It's pointing at it. Distended, inverted U-shaped loop of colon. There's minimal rectal gas, and that's about it. Let's see if we can focus on this. Yeah, this is the likely transition point or site of torsion. Okay, perfect. What else? Bird beak. If you do a CT, another way of, well, the CT finding for volvulus is going to be this thing right here. That is like a bird's beak, and the bird's beak is just telling you that this is the site of where everything is being torsion on itself, right, or revolving on itself. Of course, it's not a 3D image. That's why it's going to look like this, because it's just a little slice in space. And what else can you see? So if the patient has concerning signs of gangrene or perforation, their sigmoidoscopy will not help, right? If you have those concerning signs, of course, you have to go directly for surgery and not risk it, okay? And that's about it for that one. Let's go on to the next question. This other question right over here, let's see what's the main thing. Okay, in this patient, we have look at this, the protein gap. We've already talked about this in prior videos, but whenever you have total protein to albumin difference of more than 4 grams per deciliter, it means something's going on. There's a protein that you're not quantifying that is pretty high in the blood, and you have to look for the reason for it. So remember that in normal situations, physiological, most of your protein is going to be albumin, okay? That's what's going to give you the oncotic pressure. That's going to be what is basically moving most of the medications, and many hormones are going to be protein bound. It's going to be bound to albumin. So albumin usually is going to be about 3/4 of your protein, but sometimes it's not 3/4, so there's something unaccounted for. So in this case, for example, if you do 8.6 minus 3.8, it's going to give you about 5, right? From 4 to, let's see, from 4 to 8 is 4, 4.6, 4.7, 4.8 difference. So above 4, you have to think, okay, this is here for a reason. This is here in this question, clinical vignette, because they're trying to tell me something. Something's going on. I'm not able to count something. What is most often the protein that is here that we're not counting? It's immunoglobulins. So it's usually the gamma globulins. But it doesn't, remember that not all gamma globulins are created equal. So if you have a monoclonal Hypergammaglobulinemia, yes, that has a name, and that usually is going to be multiple myeloma or its types of, right? Its spectrum of multiple myeloma, which we'll talk about in a moment. And the other option of monoclonal gammopathy, well, of course, IgG is the most common for multiple myeloma, but you can also have IgA, I believe. And if you have monoclonal gammopathy of IgM, which is a larger molecule, it's like a pentad, it's going to give you more of a viscosity in the blood. That's going to be Waldenstrom's macroglobulinemia. That's going to be monoclonal, these options. You can also have polyclonal. So if you have an infection, you're going to be generating a whole lot of antibodies, and that's going to potentially generate this gap of more than 4 grams per deciliter, but it's going to be polyclonal. You're making a whole lot of antibodies. And there's other reasons for polyclonal gammopathy, such as autoimmune conditions, and the main thing I wanted you to focus on this question is, yes, detect this differential, this weird difference between total protein and albumin. And then you have to go look for, always think, okay, could this be multiple myeloma? Think about CRAB, the mnemonic CRAB, which stands for hypercalcemia, which we don't have. R is renal abnormality or renal insufficiency, which we do not have. A is anemia, we do not have that. And bone abnormalities, which is usually the osteolytic lesions, it doesn't seem like we have any of those here, and we have no imaging here. So the test might be saying, okay, this isn't necessarily multiple myeloma, but remember that you also have different subtypes. The spectrum of multiple myeloma is, one is MGUS, that's monoclonal gammopathy of uncertain significance. Next is smoldering myeloma, which is a little bit worse, but there's still no target organ damage. And last one is multiple myeloma, where you would see the systemic manifestations. So this is definitely not multiple myeloma, but it could be one of those other two subgroups. So they give us a little bit more information, and they add here, protein electrophoresis demonstrates a monoclonal. So they're telling you it's monoclonal. Okay, so we're in that ballpark. We're going to think about either a multiple myeloma or maybe Waldenstrom's macroglobulinemia, right? So you see that it says there's gamma globulin region that measures 2.3 grams per deciliter. So before I took this quiz, I'm like, okay, 2.3, and what am I going to do with that? What does that even mean? Well, there's a cutoff. So I think the cutoff is that below 3, you're not still in the ballpark for smoldering myeloma or multiple myeloma. Below 3, you're still in the ballpark for MGUS. And immunofixation reveals that the spike is composed of IgG. So they're basically telling you, okay, monoclonal gammopathy of IgG. So this is not Waldenstrom's macroglobulinemia, because as I told you, multiple myeloma is IgG or IgA, and Waldenstrom's is IgM. So we're still talking about something along the spectrum for multiple myeloma. And spot urine sample detects no protein by acid precipitation. So the question here, what they were asking was, what is the next step? What do we have to do next? One option was bone scan. Another option was bone marrow biopsy. Another option, I don't remember what else. But I got this one incorrect because I'm like, they didn't tell me if there's anything in the bone. Let's do a bone scan. But that isn't the right answer, because when you do a bone scans usually see or evaluate for osteoblastic lesions, not osteoclastic, or basically not, osteoblastic, not osteolytic. So multiple myeloma is an osteolytic process, which a bone scan would not be the answer. So that was a decoy option there. And actually the right answer is bone marrow biopsy, because another important factor for you to determine how to differentiate the spectrum of multiple myeloma is bone marrow biopsy. Although I didn't want to be too invasive, there's no other way out of it. If you're suspecting multiple myeloma or this spectrum, you probably have to do the bone marrow biopsy. There's only one instance where you wouldn't do it, which would be if all these findings are pretty normal. So yes, this spike has to be less than, I think, 1.5. and no symptoms at all. I think that can avoid you a biopsy in the meantime. We'll get to that in a moment. So the right answer was bone marrow biopsy. Here you can see it. And we already talked about all these things right here. We already talked about CRAB. We already talked about the spike in M protein. So look at the characteristics of MGUS. So the M protein spike is less than 3. We already talked about that. And in the bone marrow biopsy, there's less than 10% bone marrow clonal cells and no end organ damage. Okay, so now what's the next one? The next one is smoldering myeloma. So in smoldering myeloma, the M protein is above 3 grams per deciliter and or above, more than or equal to 10% bone marrow clonal cells, but no target organ damage or end organ damage. And multiple myeloma is just these things plus end organ damage, or more than 60% bone marrow clonal cells. Okay, so that's the main point here. And as I mentioned, when you can defer the bone marrow biopsy is in some low-risk MGUS patients. For example, the IgG M protein spike less than 1.5. So we already talked about it. And a normal serum kappa to lambda FLC ratio. Okay. So that's about it for that. Another interesting thing, an option here was abdominal fat pad biopsy. Whenever you see that option, they're telling you this might be amyloidosis, because that's the way you usually diagnose AL amyloidosis. But in this case, we weren't thinking about that, because for amyloidosis, you would think of some additional clinical findings, such as a large tongue, restrictive cardiomyopathy, and or nephrotic syndrome. Okay, we already talked about why bone scan was incorrect. But there is a scan, like you do check the bones with multiple myeloma, but the actual imaging to be performed is whole body skeletal imaging with low dose CT, MRI, or PET, positron emission tomography, in monoclonal gammopathies to exclude lytic bone lesions and severe osteopenia. So that was it. Let's go on to the next one. This is the first time I see all bolded answer here in educational objective. I guess they just, either they really want us to memorize this, or they just, made a mistake. It's more probably they made a mistake right over here. Okay, now we're going on to the next question here. This other question is basically telling us, this is interesting because they tell us about a 76-year-old male that has CAN, right? What's CAN? The mnemonic is confusion, ataxia, and nystagmus. When I read this clinical vignette, I read it and I'm like, this sounds like confusion, ataxia, and nystagmus. So I go to the options and I'm like, okay, where's the option for the mnemonic confusion, ataxia, and nystagmus, right? And I didn't see it, because remember that in mnemonic, was for vitamin B1 or thiamine deficiency. Okay, so that was for Wernicke's. Wernicke's is confusion, ataxia, and nystagmus. But this patient, there was no option associated with. Oh no, look, here it is, vitamin deficiency. So I thought, yes, this might be Wernicke's, but it wasn't the right answer, and that's why. Well, I marked it thinking this might have been that. But if you read through the clinical vignette, they're not telling you this patient is an alcoholic. They're not telling you this patient is just on a tea and toast diet. So they're not actually telling you none of that. They're telling you that actually he's on several medications. He's had no recent conditions. His medical problems include dementia, ischemic stroke without residual deficit, and seizure disorder. His medications are aspirin, phenytoin, levetiracetam, and vitamin D. And he was recently started on omeprazole for reflux symptoms. So this was a tough question for me. I don't know how, most people got it right here. But the main point here is remember that whenever they're telling you a patient was started on omeprazole, pay attention to it because they won't just say that for the sake of it. Is omeprazole associated to something? Yes, so the answer is maybe it is associated to something. And in this case, probably it was saying, oh, omeprazole is a cytochrome P450 inhibitor, and maybe they want you to think that omeprazole might be interacting with other medications, and that's the right answer here. So omeprazole, it basically was inhibiting the metabolism of phenytoin. Remember that phenytoin is one of those narrow therapeutic index medications. Most medications are metabolized through first pass metabolism, but this phenytoin is not first pass, it's the other one. What's the name of it? I can't recall right now. Was it zero? First, it's P450. Let's look it up. Phenytoin, metabolism, kinetics. There's first pass and zero order. I think it's zero order. Let's see if it says it here. Unique, non-linear. Phenytoin. Oh, so its elimination follows first order kinetics. Okay, so most are. The thing is that there's only 3 medications out there that are first order or non-linear metabolism, and that's PEA, phenytoin, I think ethanol, and aspirin. So it means that it's more unpredictable how these will be eliminated. It will take longer for them to be eliminated from your organism, and the reason for that is because it is saturable, so it saturates the receptors. Meanwhile, most other medications are not first pass, but different. So let's see if it's mentioned. Why is this so difficult to just answer? First order kinetics. Okay, yeah. So the other medications, most other medications out there that you might take or have been taken, are not first order. I think they're maybe zero order, but basically they're not saturable. The enzymes are usually not saturable, so the reduction is proportional to the concentration. So if you have a lot of concentration, it's going to be like a logarithmic decline. While with phenytoin, it's not logarithmic because it can just be eliminated from your body the same amount per time because the enzymes are saturated, so it's going to be taking longer. In summary, the point here is that if you give omeprazole and you're reducing the capacity of eliminating an already narrow index therapeutic medication such as phenytoin, you're going to have trouble. And you're going to be exposed to toxicity. And phenytoin toxicity is a whole lot of things. I want you to recall that whenever you see something similar to Wernicke's, which is confusion, ataxia, and nystagmus, that can also be phenytoin toxicity because it produces those same symptoms and findings, but it also produces a whole lot more things. So it also produces, here you can see it, produces things that are dose dependent, which are the ones that I told you, confusion, ataxia, and nystagmus. But it also produces those independent things. So the gingival hyperplasia, folic acid deficiency, peripheral neuropathy, rash, and IV infusion effects are hypotension and bradyarrhythmias with possible asystole. So remember, phenytoin is a sodium channel blocker, so it's part of those von Williams classification antiarrhythmics that, of course, you usually don't give phenytoin just to control heart rate, but just know that it might also cause these things, sodium channel blocker. And what else can we talk about here? I think we already talked about most things. And that's about it. Let's go on to the next question. So this next question right over here is, let's see. Oh, yeah, this patient here, look at the EKG. 1 to 2 millimeter diffuse ST segment elevation, except for a 2 millimeter segment depression in lead AVR. They're just trying to trick you there. You know that AVR goes opposite to basically all the other leads. So they're basically telling you there's elevation diffusely in all the leads because, of course, an inversion or a depression in AVR, it was going to mean a elevation in any other lead. So what causes that? Basically, it's pericarditis, right? So they're telling you this patient has pericarditis with a little bit of an elevated troponin, okay? And an ESR of 52. And the question here is, which of the following therapies most likely to cause recurrent symptomatic episodes in this patient? I got this question incorrect because I saw the options and I'm like, okay, let's start off with thinking which are treatments for pericarditis, potential treatments. Aspirin is one, right? If you have the pericarditis secondary to or after an acute myocardial infarction, aspirin might be a good option. It was called in the past Dressler syndrome. If you have the other post-viral pericarditis, which are most of the pericarditis causes worldwide, you might give indomethacin and colchicine, for example. So those are not the answer. And I also thought, well, and if it is refractory to these medications, you might go with prednisone. So I also thought, well, prednisone is probably not the right answer. And I'm like, which of this one doesn't seem to make sense? It was immune globulin. So immune globulin to me didn't make sense because I thought to myself, yeah, you don't give immune globulin usually for pericarditis. Well, I was wrong. So what's the point here? Why do you usually avoid giving prednisone in a patient with pericarditis? It's because it increases, it can help you out, it can help you there, but it can increase the recurrence rate. So there's a higher recurrence rate of pericarditis if you treat them with prednisone as opposed to colchicine and NSAIDs, right? So the right answer was prednisone. Why immune globulin was not correct? Because if you have a refractory patients, also even more refractory, you might have them on immune globulins, and that can reduce the refractoriness. But I think it's not that frequent to see these patients. I have not seen any patient in my 3 years internal medicine here or my prior residency experience that they were on immunoglobulins for pericarditis. So now we know it. So what's the other thing? Well, they're telling us about pericarditis and myopericarditis. I just want you to know that pericarditis is just the pericardial involvement. Myopericarditis is when there's a little bit of additional myocardial involvement. And if you want to even get more technical, there's perimyocarditis. So there's pericarditis, there's myopericarditis, and there's perimyocarditis. Probably for the test, they'll just mention myocarditis or perimyocarditis interchangeably. But I want you to know that technically, the worst one is perimyocarditis because it is pericarditis and a lot of involvement of the myocardium or ventricles, right? And you will have, that means that you will have worse changes on your let's see, on your echo of dysfunction, myocardial dysfunction, and also pretty bad elevation of troponin. Then you have myopericarditis, which is just saying, okay, there's pericarditis, but there's just a trivial elevation in troponin. There's just a minimal alteration maybe or dysfunction in myocardial function. And then you have pericarditis, which there's pericarditis and there's no involvement of the myocardium. We already talked about the criteria. Well, we already talked about the EKG criteria. Of course, this is the chest pain, right? That when you move forward, it gets better. So the patient has to be moving forward or laying in bed like in a fetal position. There might be the pericardial friction rub. And there might be, let's see, of course, pericardial effusion potentially on the echo. And we already talked about those other findings. And let's see, what else can we say? We already talked about all this. Okay, let's go on to the next question. So this next question is basically a patient with benign prostatic hyperplasia who was having dysuria, who had received antibiotic for a urinary tract infection, but the antibiotic then caused this patient to go into a C. diff colitis. And now this patient basically has the same symptoms, is found to have E. coli in the urinary culture, and they're asking you, what antibiotic do we give this patient now? Because we don't want to risk this patient getting treatment and now having a C. diff again. So the answer is, what you have to think about is, what antibiotic can I give a patient with urinary tract infection that has the least risk to induce Clostridium difficile colitis? So that's how you think about this question. And yes, it was oral trimethoprim sulfamethoxazole. So just bear in mind that you have some medications, antibiotics that have high risk of inducing C. diff and others that have low risk. So if they told you this patient already had C. diff, of course, choose something that has the least possibility of having risk for C. diff. Why didn't I choose Doxy? Well, Doxy is a low risk medication, but that doesn't work for a urinary tract infection. That's not a good option. Cipro, yeah, whenever you hear a fluoroquinolone, you're like, oh, maybe C. diff, right? Oral amoxicillin and clavulanate, I never give this for urinary tract infections. It's not first line at all. I don't even think it's second line, so I just ruled that out. And ceftriaxone, yes, it's great for urinary tract infections, but why intravenous? The patient is not septic. The patient probably doesn't need IV in the first place. And third and fourth generation cephalosporins are high risk for C. diff. Now let's look at the table. Here you have the table. Same things we already talked about. High risk are fluoroquinolones, clindamycin, third and fourth gen, cephalosporins, carbapenems, and monobactams, which are low risk for inducing C. diff. TMP, SMX, macrolides, tetracyclines, and aminoglycosides. And that's all you need to know for this question. Let's move on to the next question. And in this next question, what we have here is a patient that is a landscaper, but he's also used to like hunting rabbits, yeah? So they're just trying to mix things up for you, make it difficult. They're telling you that he had in his index finger, it says dorsal aspect of his index finger, he has nodules that appeared 2 weeks ago. Initially, a small papule formed and drained some clear, odorless material. There was minimal associated pain. The nodule persisted, and several days later, 2 other similar nodules formed over the dorsal aspect of the right wrist and distal arm. So it started here, then it had some drainage, odorless, then went here, and then here, right? So they're basically asking you, what is going on here? What is the microorganism? So they're telling you mycobacterial infection, no, that doesn't make sense. Nocardia infection, no. And they're also telling you that they did a biopsy and culture of these lesions. The biopsy showed mixed pyogenic and granulomatous inflammation. Gram stain, acid fast, partial acid fast, silver methanamine, and periodic acid shift. Stains are negative, cultures are pending. So they're telling you basically it's probably not mycobacterial because the acid fast would be positive. Nocardia, probably not because partial acid fast would be positive. Pyoderma gangrenosum is usually a solitary, big, ulcerated, crater-like lesion. And sportricosis makes more sense, but you also have tularemia. So sportricosis, of course, is the one that is associated with the landscaping. So that's the one that's associated with you got stuck with a rose thorn something, and that basically migrates along the lymphatics. It's not associated with systemic symptoms as much as tularemia. So tularemia also could potentially make a little sense. That's due to Francisella tularensis, and that's associated with the bunnies, right? With the little rabbits. But the rabbits will give you more fever, a little more systemic symptoms, and that's why it was sportricosis. Let's see what else we were missing. So, yes, the patient most commonly encountered form of sportricosis with the typical host being a healthy individual with an outdoor hobby or occupation, such as landscaping or rose gardening. Lymphocutaneous sportricosis begins with inoculation of contaminated moss, soil, or other organic material into the skin. Days to weeks later, reddish nodule forms at the site of inoculation. And this primary lesion typically ulcerates but can remain nodular. Adenopathy and systemic signs of infection are usually absent. Similar lesions subsequently develop more proximally and follow a lymphatic chain. The gold standard to diagnose this is culture, and itraconazole is the drug of choice for treatment because this is a fungus, remember. And the biopsy usually shows what we saw, the pyogenic and granulomatous inflammation and fungal stains, which were the silver methanamine and periodic acid, periodic acid shift, I think. are often negative because the number of infecting organisms are frequently small. And that's it. Some interesting things from the others is that Mycobacterium marinum is usually in water that is not chlorinated. So if they tell you that this guy was in fisherman, oyster handler, and started having these things, it could have been Mycobacterium marinum. Nocardia, it pretty unusually can look like sportrichosis. It would be called Nocardia brasiliensis. And yeah, for them to want you to answer that, they have to give you some clear reasons and probably not put these more common differentials in the picture. I'm just going to show you a picture of Pyoderma gangrenosum. That's that big crater right over there. So yeah. And let's go on to the next one. Well, Francisella tularensis is associated to the rabbits and exposure to ticks. Here you have fever and a single erythematous papillo-ulcerative lesion with a central eschar. Okay. Next question. Oh, this is one of the best questions. Or yeah, I learned the most from this one. So this is a 19-year-old college student. She is having generalized weakness and diarrhea for the past year. Describes 8 to 10 watery bowel movements daily, including at night. She drinks 8 cups of coffee daily. Takes no drugs. Is applying for a merit scholarship and must be at the top of her class to qualify. She is basically borderline hypotensive. Blood pressure is 92/54. Pulse is 94. Respiration is 12. BMI is 17, so she's in the anorexia range or low body weight. Well, not necessarily anorexia. Let's see. Well, anorexia, the definition was less than 18.5, I think, BMI, and you needed a couple more things. And it's not just being low body weight, right? Because not all low BMI will be anorexia. So we still are pending on that, but you can see already some clues here. Occult blood is not present. Stool leukocytes are not present. And they gave me the stool osmolarity, stool sodium, and stool potassium. And I'm like, okay, perfect. And what will I do with this? Like during the test, I had no idea what to do with these numbers, how to interpret these numbers. So I had to rely on just trying to use a little common sense. And my common sense wasn't that good in that occasion moment. So I chose the incorrect answer. I chose a VIPoma, which, looking back at it, it doesn't make any sense. I didn't pay attention. It sounds like this patient is under a whole lot of stress. She's trying to maintain her scholarship. She's drinking 8 cups of coffee a day. She's low weight, and the labs, at least these two are completely normal. I'm not sure what to make out of this. So if you see these options, probably you could be able to rule out several conditions. Crohn's, no, there's no bleed. Hyperthyroidism, not necessarily this, because this patient is just trying to grind these things out on her own. Collagenous colitis, probably not. VIPoma, no. So magnesium salt consumption was the right answer. This patient was having factitious diarrhea, and that's what's going to take us to this crazy little table. So what's this? So factitious diarrhea is basically patient is taking a laxative, so it's laxative abuse, which they won't always tell you they are actually doing that, and or adding additional substances to the stool. So they might even be saying they are having diarrhea, and you send them to get a stool sample, and they're adding water onto that. So those are things we have to consider. So let's go through this algorithm. Let's try to make it as simple as possible. So if you have a 24-hour stool collection, and you start off and you see that there is a solid stool, that's it. It's the end. This isn't diarrhea. Stool is solid. You can't tell me that you're having diarrhea for days on end and your stool is solid, right? It's not a possibility. That's it. The end. But if the stool is liquid, then you go on and measure things. Now you measure osmolality. So this is where the stool osmolality is important. So if stool osmolality is less than 250, it's way too diluted. Is this person adding water to the stool? Okay. If the stool osmolality is over 400, meaning too concentrated, measure urea and creatinine to rule out urine was added to the stool. Okay, so that's another. So you might be adding another fluid that might be complicated in this interpretation. And the normal or expected range osmolality will be between 250 to 400 milliosmoles per kg. So now you have to figure out a next step. Okay, next step, like in this patient, is going to be now let's check osmotic gap. What is the osmotic gap? It is the relationship between the measured osmolality of the stool, which we had was 330 in this patient, and the calculated osmolality here, which is 2 times sodium plus potassium. So if you do that math, it's going to give you 2 times, this is 100, 200. So 330 minus 200 is 130. So osmotic gap here would be over 130, so over 75, which is the cutoff. So next step is to think about ingestion of lactulose, sorbitol, mineral oil, magnesium sulfate, or polyethylene glycol. So that was basically what led us to think about that. If the osmotic gap is less than 75, it can be possibly secretory laxative use. So a comprehensive laxative screen to rule out saline laxatives, senna, or bisacodyl. Okay, so that's basically how you work up this factitious diarrhea. And what are these other diarrheas caused from? So they are called secretory diarrheas. So all these other options, collagenous, Crohn's, hyperthyroidism, and VIPoma, are secretory. So what does it say about secretory is that secretory diarrhea causes a stool osmotic gap less than 50 milliosmoles per kg. And that's about it for this question. So, wow, that's a lot, right? So now let's go on to the next question. This other question is interesting because it's a 79-year-old man that he's coming to see you because he's less interested in participating in usual things, but he's not depressive. So if you read the whole thing, there's just a couple things that you might say depression, but it doesn't fit the picture of depression. So this isn't depression. And he also has an atrial fibrillation with a heart rate that is at 114 beats per minute, and some shortness of breath that seems to be secondary to the atrial fibrillation. And they're basically asking you which of the following is the most reasonable next step in managing this patient. So I wasn't sure what to do here. I'm like, atrial fibrillation, and I focused a little too much on that, and I'm like, maybe rule out coronary artery disease. I'm not sure. So I chose that, but actually the answer was endocrine workup, because although this patient didn't have my typical findings I expected in the question for me to say this is hyperthyroidism. But the pearl here is that In older age, hyperthyroidism will not present as it does in people that are younger. So in a younger person, you might say anxiety, palpitations, and they're very active doing this and that. But in older people, it might lead to apathy. You're just apathetic. You're just like, I don't care about anything, and because, well, you have, and it might induce the atrial fibrillation. That might induce a little bit of heart failure, so you don't even have energy to do much of things. So the answer was endocrine workup. So that's basically what we're talking about here. Remember that in hyperthyroidism, atrial fibrillation can occur in 10 to 20% of these patients, and there are some other common complaints in older individuals with hyperthyroidism, such as shortness of breath and constipation. And that's it for that question. Going on to the next one. This other question is important because it just hammers the point of when to suspect acute or chronic prostatitis. So this, if you don't think about it, you won't get it, right? So when to suspect prostatitis. This is the patient that you have acute prostatitis. They'll give you, of course, the acute symptoms. They're going to give you the fever. They're going to tell you that this patient probably has benign prostatic hyperplasia and had a DRE, and it was very painful, and usually E. coli is positive in the urine cultures. That's going to sound more like acute prostatitis. But chronic prostatitis is going to sound like basically no fever, just persistent positive urinary culture and urinary symptoms after a full course of antibiotics, and it's still coming back with positive E. coli on the culture. That's going to be chronic prostatitis. So that's the main pearl here. We're basically asking us what was the cause of this patient's symptoms. Yes, it was chronic prostatitis, and I just told you how to differentiate both of them. The treatment for prostatitis is going to be trimethoprim sulfamethoxazole or fluoroquinolones for acute, and for chronic prostatitis, it's going to be fluoroquinolones, and for 4 to 6 weeks. That's why if you have a patient with prostatitis and you don't know they have that, you're just like, oh, this is a urinary tract infection. You're not going to give treatment for weeks and weeks. You're going to give 5 days. Basically, it can be even 3 to 5 days antibiotics. If it's complicated, a little more, but you're not gonna go over a week or a week and a half. So it was partially treated, so they're gonna come back with the same symptoms. Because prostatitis, you want to give a longer course so that it can penetrate well the prostate and actually eliminate the bacteria. So there you got it. Interstitial cystitis, so that's painful bladder syndrome, common in women who present with suprapubic pain, made worse with either bladder filling or emptying, increased urinary frequency, urgency, and nocturia. Okay, just to remember. Let's go on to the next one. This is a nice one because this was cardiovascular related, and here I just got like confused by all these murmurs going on at the same time. So I read this murmur here: a low-pitched mid-diastolic rumble and a snapping sound after S2 present at the cardiac apex. So that was one murmur. But there was also another one, which was a loud hollow systolic murmur heard over the mid-left sternal border, increasing with inspiration. So I was reading this question and I'm like, what will give me such a complex thing? Like too many murmurs, what's going on? And yeah, I didn't think about it thoroughly. In summary, I had to just understand the clinical pearl, which is the low-pitched mid-diastolic rumble, okay? That's usually going to be mitral stenosis. If it's going to be low-pitched mid-diastolic rumble in the cardiac apex, mitral stenosis. Any murmur they tell you that is in the cardiac apex, usually think mitral stenosis. Mitral stenosis, mitral regurgitation, mitral valve prolapse. Usually anything they say apex, it's going to be that for the test. So low-pitched mid-diastolic rumble and opening snap, or a snap sounding after S2, that's the opening snap, mitral stenosis. Okay, but now what's this other murmur? Loud hollow systolic murmur over the mid-left sternal border that increases with inspiration. I knew this was the right side of the heart because anything that increases with inspiration is usually right-sided valves. And hollow systolic murmur in that area, that's tricuspid regurgitation. So if this patient had bad enough mitral stenosis, the pressures can elevate and transmit to the right side of the heart and generate a functional tricuspid regurgitation. And that was what was going on. So the patient had mitral stenosis. That's why they also tell you the patient was coming from the Philippines, because that will tell you, oh, maybe the patient had rheumatic heart disease that wasn't treated, because you wouldn't expect rheumatic heart disease to go unnoticed in the US if everything is working well. So that was the answer, and those are the main points there. And yeah, Epstein anomaly will give you the apical displacement of the septal valve of the tricuspid valve, septal leaflet of the tricuspid valve. So there's right ventricle atrialization, meaning since the tricuspid valve is way lower, like the atrium is gonna be more cover more area, so that's gonna generate that problem, and they often have associated interatrial communication. And I'm just going to show you an image of the Epstein anomaly so you can hammer this in your brain. Here you have the communication between the atria, and this is the right atrialized ventricle and the apical displacement of the tricuspid valve. Okay, let's go on to the next question. We're about to finish. So this patient is a 71-year-old male. He was having some symptoms of COPD, prostate cancer, hypothyroidism. Basically, he was started on leuprolide. And the question here is, which of the following is the patient's strongest risk factor for osteoporosis? Okay, so I got this one correct because leuprolide is going to be an anti-androgenic. Leuprolide is going to be, I think, a GnRH agonist or antagonist. The thing is that it's going to lower the FSH, LH. It's going to lower it's going to generate a hypogonadal state, and that's associated with lower testosterone, and that's associated with osteoporosis. But let's see what the leuprolide exactly does. Doesn't specify right over here, but that's what it does. It just through GnRH. I don't remember if it competes with GnRH or it's a GnRH analog and it makes those go down. I guess it just tell me in the comment section below the exact mechanism through which leuprolide induces androgen deprivation. Okay, And the risk factors for osteoporosis in men, of course, hyperthyroidism, hyperparathyroidism, androgen deprivation therapy, long steroid courses, GI abnormalities where you're not absorbing things right, vitamin D deficiency, smoking, alcohol, and history of fractures, but with low impact. It's not that someone fell 10 feet, like this patient, he fell from a 10 feet ladder and he broke something. Anyone falling from 10 feet can break something. If you fall from your own height and you break something, that's going to be a pathologic fracture, and that's going to be a problem, right? So let's go on to the next question. This next question is basically just asking you, in a patient with rheumatoid arthritis, which combination of options here give you the worst outcome or the worst prognosis, meaning that you will have to, of course, treat the patient way more intensively than not. So the main point here is, of course, the more number of joints, the worse. The higher the CRP, the worse. ANA has nothing to do with this, so I felt compelled to, ANA is elevated, let's choose one that has elevated ANA. No, it's not part of rheumatoid arthritis, so not that one. Anti-CCP, yes, the higher that is, the worse. And rheumatoid factor, I thought to myself, well, what about seronegative rheumatoid arthritis? Would it be worse? And I just didn't know what the answer was. Well, the answer is that the higher the rheumatoid factor, the worse as well. So in this combination, with high rheumatoid factor, high anti-CCP, all that gives you a chance to know, this patient will need even stricter control, even stronger medications. So that's basically what we talked about here. And patients with both positive rheumatoid factor and anti-CCP may benefit from more aggressive disease-modified anti-rheumatic drug therapy compared to other patients. We already talked about that. And second to last question, this is a good question. I almost always get these colonoscopy screening questions incorrect, because it's most of the patients you see in clinic pretty straightforward, right? Most of them is going to be, okay, colonoscopy every 10 years. That's it. In the past, it was starting at age 50, but guidelines had changed. Now you start at age 45 every 10 years. But there's some caveats. So the main thing I'm going to talk to you here in these caveats is that patients at average risk, you do the colonoscopy every 10 years. Now let's just focus on colonoscopy. Now let's go to patients with first degree relative with colorectal cancer or high risk adenomatous polyp from prior, okay? If you had that, so colonoscopy would be at age not 45, but age 40. Or 10 years before the diagnosis of the colorectal carcinoma in your first degree relative, whichever comes first. So an example is, you had a family member that had first degree, so your father had colorectal carcinoma, diagnosed at age 45. So, okay, age 45, so 10 years prior would be age 35, so you just start screening at age 35. That comes first, then the screening at age 40. And then you repeat it every 5 years. Not every 10 years, but every 5 years. When would you only repeat every 10 years? Well, if the first degree family member had colorectal cancer diagnosed after age 60, which of course, well, that wouldn't be a risk factor for you, because if it was after age 60, that would mean that you would start screening around age 50, so it wouldn't come into the picture. This was just a colorectal carcinoma diagnosed at an older age. Patients with ulcerative colitis, not only ulcerative colitis, if the patient has had also inflammatory bowel disease, such as another option is Crohn's disease, with at least more than one third, let's see how much, or two-thirds, more than 1/3 of the colon being affected, extensive colon affected with the inflammatory bowel disease, more than 1/3 of it, then you would start screening 8 to 10 years after the diagnosis of inflammatory bowel disease, and then follow up colonoscopy every 1 to 3 years. And these other specific tests, I won't go into them right now. I'll let you probably pause the video and review it, and let's go on to the next question. The last question is, okay, how do you treat hyperthyroidism in pregnancy? So main pearls here is that a hyperthyroid patient in pregnancy, you don't want to just control hyperthyroidism and be like, oh, my patient is so well controlled that her TSH is below the low limit of normal. No, you don't want that, because in a pregnant patient, remember, metabolic demands are elevated. So you want to maintain a patient that is hyperthyroid during pregnancy a little bit more hyperthyroid than you would do if that same patient is not pregnant. If the patient is not pregnant, okay, control the hyperthyroidism as good as you can. Patient is pregnant, you want a little bit there so that baby can grow and all that adequately. So what should we do here? Remember that there's two medications. So first of all, if the hyperthyroidism is very mild, if it's asymptomatic hyperthyroidism, or if it's a Graves' disease and very minimal symptomatic, you might even not need to treat it. But if it's a little more than that, you might have to treat it. What are the medications? You have propylthiouracil and methimazole. You're going to have to change those two, because the propylthiouracil is very bad for mom. It can generate severe hepatic lesions, hepatic liver failure, right? But it's not teratogenic. So that means that the first trimester, you will have mom and baby on the propylthiouracil. After first trimester, so after week 14 approximately, 12, 14, you will change to methimazole. Now, all the embryogenesis, all that is finished. All the organs are sort of generated. Now you change them to methimazole, because methimazole is a very teratogenic medication, but you already have passed that time. So methimazole is not bad for mom, it's bad for baby early on, but we already passed that risky time. So now you do methimazole starting second trimester and third trimester, because it's not so bad for mom's liver. And that's the main, and you follow the labs up every 4 weeks in pregnant mom, and that's about it. That's basically the main things you need to know to answer these questions correct. You might have to use beta blockers, metoprolol, or thyroidectomy in certain cases of hyperthyroidism in pregnancy if it's pretty bad. And yeah, that's about it for this question. That's all we have for today. And remember, radioactive iodine is contraindicated during pregnancy. And I'll see you in the next one. This was a tough one, and I hope you liked it. And now I'm gonna take the dogs out in a moment and do my other block. And yeah, leave me comments, feedback. Did you like it, not like it, etc. See you in the next one.